So here's my organization scheme for acute kidney injury, and first we're going to talk about global perfusion of the kidney. As you can see, I've put up here Ohms Law, which comes from physics classes you may have taken in the past, but essentially the voltage equals flow, which is I, times the resistance, and we can rearrange this to be flow equals the voltage divided by the resistance. Now let's rewrite this in terms that make sense for the kidney. Okay, so we care about flow in the kidney, so flow equals, so we're not talking about voltage, but we are talking about pressure, so the delta pressure on both sides of the kidney divided by the resistance. So there is resistance in the kidney, mainly because of the afferent arterioles, and so we can basically understand kidney blood flow in terms of the delta pressure divided by the resistance of the resistance vessels, which are the afferent arterioles. Alright, let's look at this more closely. Okay, now you can see I've rewritten this equation to help define some of these terms. So the delta P in this instance, when we're thinking about kidney perfusion, is basically the pressure difference between the inflow and the outflow. So what's the inflow? Well, the inflow is the mean arterial pressure. Remember, this is the pressure of the blood flow coming in the renal arteries right off the aorta. And then what's the outflow? The outflow is the renal venous pressure, so the pressure in the veins coming out of the kidney. So for the kidney to work, to get good perfusion, you need good inflow, you need good outflow. Essentially, you need a low venous pressure and a higher mean arterial pressure, and this difference forms the delta P part of this equation. The other piece is the resistance of the afferent arterioles. Remember I said most of the resistance is derived from the afferent arterioles, and then some also comes from the efferent arterioles. Okay, so let's go through each of these terms individually. As you can see, this will help form a differential. So first, let's think about things that will affect the arterial pressure or the inflow into the kidney. So things that would drop arterial pressure into the kidney, so things that would drop the mean arterial pressure throughout the entire body, like shock, so hypovolemic shock, cardiogenic shock, or distributive shock, certainly would also affect the kidney. Other things, like think about vascular causes, vascular disease, so aortic dissection, let's say a ruptured AAA, renal artery stenosis or severe atherosclerosis or a dissection in the renal artery. Any of these things would cause a drop in the arterial inflow into the kidney or the mean arterial pressure of the entire body. So now let's consider things that would increase the renal venous pressure. Remember, we want a relatively low renal venous pressure so that the outflow of the kidney has a place to go. And if we increase the renal venous pressure, we will affect global kidney perfusion. So what are some things that will increase renal venous pressure? You can see here I've added some common causes. So congestive heart failure with right heart failure, anything that would raise right heart pressures, increase the IVC pressure, and that will transmit down to the renal venous pressure. So sort of in the similar category, severe pulmonary hypertension that's causing right heart failure can do this. And really any cause of really severe significant fluid overload will expand extracellular fluid and can increase IVC pressure and ultimately the renal venous pressure. But also consider some other causes that are maybe less common, like thrombosis. So thrombosis of the IVC, thrombosis of the renal veins, that would increase renal venous pressure and affect kidney function. Also think about compression of the IVC or renal veins by tumor, any kind of mass. A severe bleed can compress the veins. Any kind of intra-abdominal process can cause compression of renal veins, and that's a severe problem. Also, let's consider common clinical scenarios where you'll see both low mean arterial pressure or arterial inflow to the kidney with very high renal venous pressure. And a couple of these, the cardiorenal syndrome. So this is some combination of either low arterial inflow or high renal venous pressures, or both, that's reducing kidney perfusion. Also the hepatorenal syndrome, which we see in patients with typically end-stage liver disease. They have low mean arterial pressure due to splanchnic vasodilation. they have high renal venous pressures because they're retaining sodium, and they have extracellular fluid overload. They also have some ascites typically, so they are very prone to developing kidney injury. Also, the abdominal compartment syndrome. So this can occur due to either a perforated viscus with severe peritonitis, severe tense ascites in that liver disease patient, or even a severe bowel obstruction. So anything that increases peritoneal pressures can, number one, cut off blood flow into organs such as the kidneys, or clamp off venous return. And if both of those are occurring, the abdominal perfusion pressure is essentially choking off perfusion to organs. And so this can happen to the kidney. And it's something worth considering, especially if you can't figure out what's going on with the patient, and especially in the setting of critical illness or total body fluid overload. Now, I'm not trying to ignore this R term down here, so let's focus on that. But compared to at least the mean arterial pressure and the renal venous pressure, remember, we can't directly measure the resistance. We can measure the MAP, we can measure the renal venous pressure, and even estimate these things using physical exam. But the resistance is a little more tricky, but it's important to know which things will affect the resistance. And so sympathetic nervous system activity will affect resistance in the arterioles. Also, we know that the RAS system, the renin-angiotensin aldosterone system, so angiotensin 2 will cause vasoconstriction of the afferent and efferent arterioles. Obviously, everyone knows that it causes a preferential vasoconstriction of the efferent more than the afferent. It's weaker, but this just illuminates some of the clinical syndromes we see. So imagine which patients have excessive sympathetic nerve activity and activation of the RAS. So patients with CHF, patients with cirrhosis, any patient undergoing surgery or maybe trauma, sepsis. So in all these instances, sympathetic nervous system and the RAS is being activated to try and maintain organ perfusion pressure, to maintain extracellular fluid volume, even if you're already volume overloaded. Remember, this sort of a maladaptive physiology. So in all of these settings, the resistance is at least increased. And as you can imagine, since it's on the denominator, an increase in the R will also factor into this equation and decrease perfusion. So the unhappy triad is listed above: a low arterial perfusion, high renal venous pressure, and high resistance. So I think this equation really does help when you're considering the differential diagnosis for acute kidney injury in the setting of a global perfusion problem.